From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, I'm Dr. Preeti Malani, Associate Editor at JAMA and Professor of Medicine at the University of Michigan. Today, I'm joined by my colleague, Dr. Carlos del Rio from Emory University's Department of Medicine. And like myself, Dr. del Rio is an infectious disease physician. Welcome, Carlos.
Happy to be with you.
So, Carlos, we've been friends for years, but during the pandemic, we've developed this interesting and close collaboration, writing several viewpoints together on COVID. And now we've pivoted our attention to monkeypox. So we published a viewpoint in early June titled Monkeypox in 2022, What Clinicians Need to Know. And things have continued to evolve. So we wrote a second viewpoint, aptly titled Update on the Monkeypox Outbreak, which was published online August 11th. In terms of monkeypox, the outbreak has grown and, in fact, has been declared a public health emergency of international concern by the Director General of the World Health Organization on July 23rd. And on August 4th, the Biden administration followed suit, declaring monkeypox a public health emergency in the US, which helps federal agencies direct funds towards the response. So let's start by talking about what is known about how monkeypox is spread and what is unknown. We know that the virus is primarily transmitted through direct skin-to-skin contact with infectious lesions. In the current outbreak, almost all known cases have been identified among men who acquired monkeypox through intimate contact with other men. What else have we learned about transmission?
When we talk about a skin-to-skin contact, it could also be mucosal to mucosal contact. So it could be rectal mucosa, it could be the oral mucosa, and we need to remember that that is, in a way, part of your skin, that the mucosal surfaces are a place where we're seeing transmission. The other issue is that the virus is found in the genital secretions, and it has been isolated in semen, for example. And so there's a possibility that it can be transmitted through secretions as well. And that's one of the things that needs to be understood more carefully, because if it's transmitted through genital secretions, such as semen or vaginal fluid or saliva, I think we're going to be talking about a very different approach than what we typically have thought about this virus in the past. So there's a lot still that we need to understand about transmission. And there's a lot that we have to understand about transmission, because it's going to be very hard to really talk about prevention without fully understanding exactly the ways of transmission.
One thing that we wrote in the viewpoint was that casual contact is not how this is transmitted. And can you reflect on that a bit?
We start seeing people worry about it. We found the virus on door handles, and the virus can survive in water, and we find it in surfaces, and therefore we would need to clean them very well because it may be transmitted that way. Well, I remember the early days of COVID, right, in which we were all cleaning our grocery bags at home, and we were cleaning our pizza boxes because, quote, the virus was there. Well, that's not how the virus was transmitted. And we learned that. I have nothing against keeping surfaces clean. I'm all about hygiene and cleanliness, and I love doing that. But I do think we need to start being careful about wasting resources in cleaning surfaces, thinking that we're doing that to prevent monkeypox. The evidence is pretty clear in a city like New York City, where everybody takes a subway, everybody takes Ubers. If the disease was transmitted through casual contact, we would see people infected in a very different way. It wouldn't be primarily an epidemic among men who have sex with men. There'll be more women and more children and more other individuals. So I think we need to reassure the public that casual contact is really not a way in which this virus is transmitted. And also my concern is this, with the thoughts about casual contact, that simply increases stigma and discrimination of people with monkeypox, and that is something that we have to avoid.
Although this is a global outbreak, the epicenter, especially the early epicenter, has been Europe. And there's been some suggestion of slowing case counts in Europe. What are you hearing, and is this good news for the US and other nations?
First of all, the virus is being transmitted primarily through sexual networks, right? And if people start having less sex, there's going to be less transmission. People have probably stopped having raves and a lot of parties, and that's going to slow transmission. And then there's vaccination associated with it. So we're going to see slowness of transmission just because of behavior change, but also because of vaccination.
Let's talk about clinical characteristics. What are some of the key things that we're learning about clinical presentation of monkeypox in 2022?
Well, the classic monkeypox presentation was the prodrome of fever, malaise, headache, and then with lymphadenopathy, and then appearance of the skin lesions. The skin lesions could start in the hands or in the face, depending on where you were touched. But in this current outbreak, we're seeing sometimes The lesions start together with the prodrome or even before the prodrome. And we're seeing the lesions to be sometimes one lesion, sometimes a lot of lesions. But a lot of the lesions are occurring primarily, are beginning to occur in genital areas. And therefore, they could be in mucosal areas. And I look at some of those lesions, for example, in the perirectal area. And in the past, I would say this person has herpes, right? I mean, all the lesions look very similar to other STDs that we normally had seen in the past. And I wonder how many more times we have been missing monkeypox because it was there and we just didn't pick it up. So I think the awareness right now is that the disease is not what we thought it was. And the disease looks more different with a lot different manifestations. And I think the genital lesions is really something that is very striking. And I think a man or a woman, for that matter, walking in with genital lesions today needs to be considered as potential monkeypox until proven otherwise.
Yeah, so speaking of which, what is the status of testing capacity and turnaround time? I know clinicians have lots of questions on how to test, what not to test, and how all of this should be done. So, who should be tested and how, and what is the status of testing?
The states were initially doing all the testing, then CDC approved 5 commercial laboratories to do testing. Currently, testing capacity in the US is about 8,000 tests per week, and we're testing only about 800 people. So we're still not testing as many as we should be testing. Now, part of the problem is clinicians may not know how to test, what you need to do. They worry about the follow up. I have heard clinicians say, well, how am I going to get the results? How am I going to get it to people? What do we need to do with the result? So I think there's still clunkiness on testing because it's still not as efficient as it should be. And again, this is going to be working with emergency rooms, working with urgent care centers, working with sexual health clinics, working with HIV clinics. I think one thing we haven't mentioned is, anywhere between 40 and 60, 70% of cases, regardless of where you look, are people living with HIV. And therefore, HIV clinics are a critical point where we need to be doing the testing, we need to do vaccination, we need to be doing therapeutics.
So let's talk about treatment. In our initial viewpoint, we mentioned multiple possible treatments, but right now in the United States, it's really only one drug that's being used. It's Tecovirimat or TPOX. And this is an antiviral drug approved for the treatment of smallpox based on animal data, and it's been made available to treat monkeypox via an extended investigational new drug protocol, so an IND. And initially, we were focused on people who are immunocompromised, who have disseminated infection, but what I'm seeing is that it's being used much more liberally now with anyone with severe disease. What are we learning about the effectiveness of tecovirimat and any indication that this might become more easily available?
Number one is we know it's fairly safe. We have human data that it's very safe. We have no human data that this works against monkeypox. We have anecdotal reports. There's publications of case reports saying, yeah, it improves the lesions. But the reality is we need clinical trial data. And there are a couple of clinical trials already happening or about to start, including one by the WHO, one the NIH is doing in Central Africa, one the Europeans are doing, and the ACTG is about to also start a study looking at the effect of this drug. So I think we need clinical trial data to know if this works or not. One of the concerns with TPOX is that it's a drug that acts in a very specific site, and one single mutation at that site could produce resistance to this drug. So I think we start using it very liberally. We may be in the risk of inducing resistance, which would be potentially a very serious problem. That to me is also one of the issues that we need to look at. But in a clinical trial, we have to understand not only does the lesions improve, does the infectivity decrease? Because if we're able to decrease the viral load of the individuals and the infectivity, treatment also is prevention, right? Treatment will allow us to slow the spread of the infection.
So, speaking of slowing the spread, let's shift to vaccines. So, currently, two vaccines can be used to prevent monkeypox, but from a practical standpoint, only one is being used. This is the Janus vaccine, which was FDA approved for smallpox and monkeypox. The other one is the ACAM 2000, which is approved only for smallpox, but granted an expanded access IND protocol allowing for use against monkeypox. But again, it's not being used from a practical standpoint. One helpful feature of both vaccines is that they can be administered as post exposure prophylaxis. So, when given up to 4 days after exposure, vaccination can prevent disease altogether, but even getting it up to 2 weeks following exposure can reduce symptom severity. And the Janus vaccine is what's being used in the US, and it's a much safer vaccine, but the supply is severely limited. And in fact, it's made by a small company in Denmark, and it's a 2 dose vaccine. But something happened last week that should improve supplies. So on August 9th, the FDA authorized an emergency use authorization to allow intradermal injection for adults at high risk of monkeypox. Can you just talk about that? And I know you've been involved with some of the discussions and some of the calls, the clinician calls.
Well, this is not the first vaccine we can shift to intradermally. I remember, for example, in hepatitis B vaccination in many resource limited countries, in order to use the vaccine to have more availability of vaccines, many places went to intradermal administration because you can decrease the dose and you get the same immunogenicity with the MVA vaccines, with the monkeypox vaccine or the smallpox vaccine, the MVA vaccines, the modified archaea virus vaccine. Would you get the same immunogenicity, but you may get some more reactogenicity. The challenge with doing this is also that you need to learn how to do intradermal administration. A lot of people don't know. You and I probably were old enough to have done PPDs. That's intradermal. But nowadays, who does a PPD? So we have to bring our retired TB nurses out of retirement and ask them to please help us train people how to do intradermal administration, because it's not simple. It's something that we're going to have to turn people. You need different needles, different syringes in order to do this. It does allow you to decrease the dose significantly. You can use a fifth of the dose and get the same immunogenicity. But again, the challenge is we don't know the efficacy of this vaccine in the prevention of monkeypox in the current outbreak. And we don't know the efficacy of the lower dose. So we need clinical trial data. And we're right now in a pretty much in a data-free zone. And monkeypox has been endemic, and there's been a significant outbreak in Nigeria since 2017. And we had the opportunity to test these vaccines, to test therapeutics in Africa since 2017, and we didn't do it. And because we didn't do it, we don't have the data today. So again, if something is happening in Africa, it should matter to us.
Just a word about the ACAM 2000. This is the other vaccine. And for context, there are 100 million doses of this vaccine in the national stockpile. And again, it was stockpiled not for monkeypox, but for smallpox. Can you just review what the concerns are about using this, since a lot of people do raise this as an option?
The ACAM vaccine uses a live vaccinia virus, and it's administered the same way we used to administer the Dryvax vaccine, the original smallpox vaccine. It's with a bifurcated needle, and you go into the arm, and you do multiple punctures, and you get local replication of the virus there. The nice thing is one dose, one-time administration, not twice like the Janus vaccine. But the concerns are that because you have local replication, potentially that person can infect others. And in some individuals, you can get significant reactions. You can get disseminated vaccinia, for example, in people that have eczema. You can see disseminated vaccinia. But you can also see other complications such as encephalitis, and particularly pretty high risk of myocarditis and pericarditis with that vaccine compared to the Janus vaccine. And that's the reason why, up to now, most people are really in favor of using the Janus vaccine. But I tell you, if this outbreak gets out of control, I think the ACAM vaccine would certainly be a vaccine that I would consider using. Now, the other concern is that we don't know about the risk of giving a live virus to somebody with HIV. And if 40 to 60% of individuals are people living with HIV, I would be very reluctant to vaccinate anybody with HIV with this vaccine.
So for now, ACAM 2000 is going to stay where it is. Let's talk a bit about prevention of spread. The healthcare setting has had a lot of practice with prevention in the last few years with COVID. What about individuals with monkeypox? What does secondary prevention look like? And should people be isolating? What about quarantine?
Let's start by saying that up to now, there hasn't been a single case of a healthcare worker diagnosed with transmitted monkeypox in the healthcare setting. So let's start by saying that what we do in healthcare to prevent infections is working. Because of COVID, we're all wearing masks, we're frequently wearing eye protection, and we know how to put PPE. We know how to use a gown and a gloves. So my point is, if you have somebody with suspected monkeypox, somebody with a skin lesion, somebody with a genital lesion, they should be put in a single room. They don't need special air handling. The lesions need to be covered. It's good to have the patient wear a mask. And then the healthcare provider should also wear a mask, eye protection, a gown, and gloves, and then go in and examine the patient. And the kind of prevention that we need is things that we're used to in contact precautions. Now, most people don't get admitted to the hospital. They're sent home. Many were diagnosed with telemedicine. The recommendation is that the individual stays in isolation until all lesions resolve, and that may take up to 4 weeks. And having somebody in isolation for 4 weeks is pretty unrealistic. Think about it, not going anywhere for 4 weeks. So we also need to think about what are reasonable ways in which we can tell people what they can do and what they cannot do. And up to now, we really have not seen that. And I think we need to develop sort of a harm reduction approach that allows individuals to say, look, after 2 weeks, this is what you can do in order for you to be able to go out, in order for you to be able to continue your life. Because staying in isolation for 4 weeks, there are very few people that can even afford to do that.
Yes, indeed. And I think this gets at the need for data, especially around treatment and whether that speeds up the healing process and shortens the period of infectivity. So I want to shift back to public health, and you made some comments about this already. We end the viewpoint talking about the importance of public health and global health. And I'm going to just read the last paragraph. Despite monkeypox being endemic in Africa for decades, clinical trials on treatments and vaccines were not done. Now, more than 3 months into the global monkeypox outbreak, there's much to learn. While test capacity has been increased, more is needed. Contact tracing is not happening, and data systems are not informing the response in rapid fashion. Many individuals at risk for monkeypox may not be engaged with the healthcare system, making diagnosis, containment, and prevention challenging. The demand for vaccines far exceeds availability. Although the supply of Tecovirimat has increased, the drug must still be used under an IND protocol, which limits access. In addition, a decentralized and wholly under resourced public health infrastructure is even more strained as officials must now respond to both COVID-19 and monkeypox. Carlos, what scares you and what gives you hope?
Well, what scares me is that we're repeating many of the same mistakes we committed with COVID. And again, we don't seem to be learning from our lessons. We seem to go back to the same way of doing things. And I think we really need to rethink how we respond to diseases. We all said COVID is not the first nor the last pandemic. Well, now we have monkeypox on top of COVID, and we may easily have another thing. So we need to be able to be more nimble. We need to be able to be more responsive, and we need to be able to be much more rapid in action. I mean, when this was emerging in Europe, we should have been preparing right there and then, not waited until it started here in the US to start doing something. But what gives me hope is that I think we're seeing what I would love to see more is this closer collaboration of public health and clinical medicine. And all of us have known that this is really critical in the success in our country. We have a healthcare system. Healthcare is over here. It's about providing not really health. I think it's about disease care. We have a disease care system and we have public health. And somehow we need the disease care health system and public health to meet more in the middle, where we can really truly do prevention, where we can really do early treatment, where we can really do care and not wait until people get terribly ill in order to take care of them. Let's think about another disease, diabetes. We're really good at dialysis and amputations for people with diabetes and doing cabbages and angioplasties. But how can we bring prevention more into the clinical setting? How can we make that not only something that is doable, but the healthcare system wants to do it because it's rewarded and it's compensated appropriately. And then you bring public health into the equation. And I think at the end of the day, you have better health for the community. So my hope is that we will see really a reorganization of our system in a way that we're more individual and community centered and less about the systems and more about the response to what the individuals truly need.
I'm glad we could end this conversation on a positive note. So thank you, as always, for joining me today. This episode was produced by Jesse McQuarters at the JAMA Network. The multimedia team here also includes Daniel Morrow, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.